So, with that, with this increasing use of next generation sequencing for mutation profiling, how do you recommend, or what is your approach to integrating these results into things like routine decision making for patients with suboptimal
Well, for
TPN?
for people listening to me today, let me be clear. When we talk about NGS, there's two kinds. We look at the kinase domain mutations, or we look at the myeloid mutation outside the kinase domain. What practice today is to look at the kinase domain mutations by NGS or PCR. Today, there's no indication to check for mutations at the baseline or is somebody responding. We only check for these mutations in somebody losing his or her response or not responding, because then if we identify a mutation, that can dictate the choice of next line of therapy.
Mm. And then are there guidelines or specific kind of resistance mutations or patterns that prompt maybe earlier consideration?
I mean, if a patient not meeting good milestones and resistance is defined by the lack of achievement of a transcript below 1%. Anything above 1% for me is resistance. Any patient who do not achieve at 6 months transcript below 10% is resistance. At 1 year, 1%. Now, anything underneath these levels is not resistance. So, for example, if somebody had a PCR at 18 months where the BCR-ABL cell level is around 0.5%, this is not something to worry about. Only I would worry about it if the level remains above 1% beyond 12 to 18 months. In this setting, I'll check for kinase mutation, but not for somebody with a minimal disease, because this patient can expect to have a normal lifespan still.
Mm. Speaking of PCR, how do you see the role of digital PCR and maybe other ultra sensitive methods evolving for MRD detection and things like
I think
CML?
we moved away from PCR, Sanger sequencing PCR at 20%. We're all using NGS today with a sensitivity of 1% or less, which is even better because it allows us to tailor therapy in a better way. Because we know with the Sanger PCR, having no mutation doesn't mean you don't have any. And NGS allow us to detect these mutations that can help us tailoring our next line of therapy, and that's very important.
Mm. How close do you think we are to using things like genomic instability markers to guide maybe frontline therapy?
I think we're doing so well in frontline therapy. I think what dictate our choice of frontline therapies are the price of the medicine, the goal of therapy, be it survival only, because if you're aiming for survival, all TKIs are identical regardless of genomics, or TFR, mean inducing treatment-free remission. Patient comorbidities, because each drug has its own side effect. And finally, the risk score of the disease, high tumor burden, low tumor burden. I think where genomic instabilities play a role is more in blast phase disease, or advanced stage disease, where progress has not been at the level seen in chronic phase.
Mm.